The Agenda is powered by DART, Delaware's transit service, moving forward.
Kerwin Gaines here, host of The Agenda. Welcome back to all our first-time viewers. Welcome. We're glad you're here. We're glad you made a choice of DETV and choosing us, that is The Agenda, to show you all the things that are going on down in Dover and what are important to you and your family. No difference this week. This season has been great. We've made it very clear to you that we are listening to your requests, that we're receiving on social media, that we're receiving from people walking up to us in Target and saying, I want to know more about this. And this is no exception today. We have Representative Paul Baumbach right here from Dover. Welcome, Representative Paul Baumbach, and Dr. Jeff Gardere as well. And we're here to talk about House Bill 140, which is very important to so many people right now, and that is death and dying. It is a very sensitive topic. We're not going to skirt around it today. We're going to take the questions that I believe that you want to know, and it would have been in the hearts and minds of so many families, and bring them forward here on the show to make sure that your ideas in regards to this maintain on the agenda, and make sure that Representative Baumbach knows how you want to be represented right here in Dover. So we're excited. Thank you, gentlemen, for joining us here on the show today.
My pleasure.
Thank you so much.
To be
This
with
is
you.
not your first time, Representative Baumbach,
not.
on the show. We love it when people come back. Not everybody does.
Satisfied customer.
Satisfied customer. But both times have been in support of this legislation. It is important to Delawareans. It is important to everyone. And I have to choose my words very carefully here because this is a very sensitive subject, but it is becoming more popular within the United States. The importance of making that decision at the time of expiring and having that power. Some people think that power is not up to us. Some people do believe that power is 100% up to me. And what's making the difference between how this has happened in the past versus how this is happening currently is legislation. And you have been on the forefront of pushing this through Dover. Tell us a little bit about your experience in doing so.
Sure. So this is something I've been working on for about 10 years now. And it was brought to me by some seniors who were playing tennis in the court next to me. And they said, this is a big issue. I was a pretty new legislator, and they said, we need you to bring this forward. And I've been working for 10 years on this. Initially, I couldn't get a single legislator to join me on this. Mm-hmm. And this year we had a majority in both the House and the Senate to support this. So as you say, it's growing and people have learned more and more. I started working on it shortly after, or around the same time as Brittany Maynard and her saga in California came up where she was dying from a brain cancer. And this process was not legal. So the government stood between her and her doctors at that time when she was dying. And she and her husband had the financial abilities to move to a state where it was legal, to Oregon, and she could take advantage of that. In reaction to that, California's legislature took it up, and they passed it, and it's now law in California. It's law in a quarter of Americans live in a jurisdiction where the government doesn't get between you and your doctor when you're dying. New Jersey, it's legal. I'm working to make sure that Delawareans have the same rights as New Jerseyans when they're dying. Yeah.
As I was saying, the popularity is increasing, but I mean, you made it through the House, I believe it at 2116, somewhere around there. The Senate, you had some serious discussions with them, and it is now on Governor Carney's desk for signature?
It's the way the process works is once it passes, it goes back to the original House. So it's sitting in the House and is waiting for the House to officially hand it to the governor.
Okay. So our governor's term is ending. You find when politicians, their terms are ending, sometimes their decisions are a little bit more, reckless abandon, so to speak, in regards to what they've done in the past, because their political consequences in their minds they see as no longer. Our governor, who's been on this show a few times, has very conservative views, I would think, in regards to certain issues. I don't know exactly where he stands on this issue, and I won't even begin to quote him, but these are serious things to decide. What has been your feeling about how that's going to go?
So the governor has spoken about this over the years. Now is his 8th year on this topic. He's never been a cheerleader for it. And yet, I think just as the legislature, when I first brought this forward, there were no cheerleaders for it. But I'm hopeful that with 8 years of having information cross his desk, we've had surveys showing 70% of Delawareans support that up and down the state. Every county.
70% of Delawareans support the legislation as it is right now. 72%.
Yes.
Okay.
And that includes strong majority in all 3 counties and the city of Wilmington. So I'm hoping that in the targets, people are coming up to him and saying, please let this become law. Because I've seen, they say to him, I would hope, I've had a relative, I've been at their bedside as they were suffering in their final days, and it is miserable. And they may also say, and I really like the fact that this is a choice. So if this is a person who's dying who does want to leave it in their God's hands, then that is what they were able to do. This does not change that at all. This completely puts the power of the agency into the hands of the dying person to work with their willing healthcare professional.
Dr. Gardere, I'm going to jump to you. You understand, because you've dealt with this, you've worked with families, you've worked with patients and in their time of dying. So what is the consensus that you're getting from these families? Are they seeing it as being forced upon them, or some sort of death pressurization, or is this relief?
I think it's relief for a lot of people, just having the choice of being able to have the freedoms when you're healthy, and also have the freedoms when you're deathly ill, when you're at the end of life, is something that is very, very important, not just for the psyche and the soul, but spiritually. And that's one of the things, an example would be someone who perhaps needs to go into assisted living. And we know, for those of us who've taken care of older individuals, I have, many of us have been in that situation. That person going into assisted living may not want to do that because they feel that they don't have a choice. It's something that's hoisted upon them. Here we're talking about having the freedom to determine what you want the end of life to be. That kind of liberation helps you to be able to handle the transitions of getting older. I've spoken to many people who are not at the end of life, who are in their 60s, for example. And these are individuals who are saying, hey, I just want to know that, if there is a situation where I have less than 6 months to live, I am in horrible pain, nothing can be done, and the pain is getting worse, that I at least have the choice of doing something that I know is part of what I need to have in my life. And so this is something that is so important, not just physically, but emotionally, as I've said, psychologically.
So just to bring everyone back up to speed, I'm Generation Xer. We talked about there are people that are before me, there are people that are after me, but in my generation growing up, we had Dr. Kevorkian. Dr. Kevorkian, for those who don't know, was a Midwestern physician who assisted several people in regards to dying by using a homemade machine, facilitating, gave the people the opportunity to facilitate it themselves or through assistance. Some of that was determined in the courts to be legal, and he served prison time for doing this. The difference between you and his methodology is the legislation and the permission to do so legally. And a lot of folks felt that he had a God complex. He was taking matters into his own hands and forcing death upon people in their time of dying. I think it's very hard for me to understand. I'll be honest with you, sir. I mean, in your time of dying, it's really hard to make a great decision, I would say, right? In regards to life and extension of life and what have you. What would you say to people who feel that this legislation is giving folks the opportunity to play God and choose whether or not they can live or die, a decision that they don't think, several people don't think should be up to them?
So several things in there. With Dr. Kevorkian, that was the doctor making decision for a patient. This is the patient making the decision, and that is critical. There's also safeguards to make sure, there's so many safeguards in here to make sure that this is the opposite of a Dr. Kevorkian scenario. It is one where you need to have multiple doctors, multiple healthcare professionals confirm not only a terminal
Including
disease,
psychologists.
including if needed. And
If needed. If it's a
Okay.
situation of where the two doctors are unable to make the decision around a mental health issue, around this competence, then they can have a psychological exam.
So that is the safeguard to make sure the situation you raise, that the person is able to make a calm, cogent decision and is not being racked with the disease-led issues that causes them to make poor decisions. So we've got a safeguard for that. We've got the safeguard to make sure not only a terminal disease, but a terminal prognosis. Because you can get prostate cancer, it may not lead to your death. It may just make things a little bit worse gradually over time. It has to be something that two different of the healthcare professionals have confirmed their best understanding from all their experiences is 6 months or less. And it's not that I passed that, now I can get the medicine and take it. No, two things. One is you got to wait weeks. So it is something like, it's sort of like having a amount of time before you can buy a gun, a waiting period. You have a waiting period for this also to make sure it's not the heat of the moment. You got that diagnosis and you panic, you run out, get this prescription and you take it that night. Absolutely not. Safeguards that prohibits that being possible. So those safeguards are done to make sure there's no abuses. This has been in place, I like to say, since last century. Late 90s, Oregon took this up. We have decades of evidence of how this is used responsibly without abuses because of those safeguards. And that's why 10 years ago, 8 years ago, 6, 4, 2 years ago, when I bring this legislation forward, it has all those safeguards which have been proven to make sure that this works. And it works to make sure the dying person who is mentally capable is able to make the decision if they choose to utilize the medication prescribed by the healthcare professional.
Does that limit the bounce back? And what for those at home, what I mean by that is I have been with family members who are not doing well, to the point where we call family members and say, hey, you might want to come on a plane, you might want to come up and see whomever. This doesn't look good this weekend.
Yeah.
They make a miraculous recovery. They come back and have more quality time of life. Starting that process, I hear that you're saying, hey, we have a safeguard. It's going to take weeks before you get it. But are we taking away the ability for life to come back in?
I would say that we're actually adding the ability for life to come back in, because what you're losing without this, what Delaware's dying have right now, is no hope. So when they have that terminal diagnosis with no guarantee of pain control, they don't know that. It's uncertain, and they only get one chance to die. They don't know what that path is going to be. When this becomes law, they will have that ability to have medication to take if it becomes insufferable, okay? And that means that in their days before that, they can live the life they want in their final weeks, which they can't do if they're worrying, oh my gosh, it's gonna be so bad, I'm gonna be screaming at my grandchild because the pain is so bad. That's the quality of life we're giving back to people by making this become the law. And that's the quality of life that we're withholding from people by not letting this become law in Delaware.
And Paul, I agree with you. Kerwin, these are people who want to live. They don't want to die. They want to live, but they want a quality of life as they also want a quality of death. To not be in a situation when they're transitioning where they're not only in pain physically, they're in pain emotionally. All hope is lost. They are just suffering. They're just a shadow of the person that they once were. So echoing what you're saying and what I said earlier, knowing that you have a choice is so important psychologically. It really does, in many ways, bring more life to you emotionally. Some would even say physically. So that's something that we always have to keep an eye on. The other thing is that these are not conversations that people have when they're in their last 6 months of life.
It's probably hard to find a family member to have that conversation with them in a pleasant fashion.
And that is you hit it right on the head. We want to be able to have people talk to their doctors, talk to their spiritual leaders, clergy, and so on, but especially family. Having these verboten type of talks, the stigma about talking about death. Death is as natural as life. It's the other end of that continuum, that spectrum. And so it's really important that we be able to allow people, enable people, empower people to talk about death. What kind of death do you want to have? What are your thoughts about death? What kind of relationship do you have with the people around you where, you have your advance directives, for example? And when we talk about this medical aid in dying, by the way, and doctors talk about it, of course, it's brought up by the patient to the doctor. The doctors are required to not only talk about medical aid in dying, but all other options that are on the table with regard to end-of-life treatment. So this is a comprehensive conversation that in many ways hopefully keeps us from making a decision that some may think, well, did they really think it through? But again, having the physicians involved, when necessary, a mental health person, to make sure that person is competent and knows exactly what they're doing. That is important.
I want to be honest with you, Doc. I'm hearing, when I hear this, and I try not to play this card, so to speak, I hear a lot of privilege in this, right? And I don't think that, and I get the privilege, and I want to tell you what my census is of this privilege. My census is that I am one of those folks that read the obituaries every week. Okay, I am that. I still get the paper on Sunday to read the obituaries. All right, I said it. But I see people who, in their obituaries, say they've died at home surrounded by their family.
Yes.
And then I see, and it's almost warm when you read it.
Oh, yes.
And then you can tell the people who died in such and such care facility, Christiana Hospital, so on and so forth. And then you can kind of tell from the areas, because they'll give you the towns in which these people live, there's a little disparity in how people die.
Absolutely.
There's a little disparity in regards to how people die and where people die.
That's right.
So what are we doing to ensure that this is, what we call it, a procedure option, is being fairly distributed from a communication standpoint? Because the quality of the doctor, I believe, is important to be able to explain this to you in regards to all your options and walk you through and be knowledgeable and non-biased about it, versus someone who does not have that option. And caveat to that, if legislation is a part of that, what are we doing from a governmental standpoint to ensure that this is a non-biased option for all folks within our community?
So there's two things that I'll start on. One,
I'm sorry, that was a big sandwich.
No, it's fine. It's all safeguards. And so, as Dr. Jeffs mentioned, not only would the health professional share, okay, this option is available to you, but they can only do that legally. They can only say that in the same conversation with, and here are the other 15 things you can consider. Okay, and in the same conversation of, you're terminal disease, and I feel you have a terminal prognosis, 6 months or less to live. And let's talk about your treatment choices. And if you want to if you want to not do the treatment because of, it's chemo, radiation, it's stuff that you've gone through maybe 2 times already, and you know what that means. And you're like, you know what? I'm 92. I've gone through that twice. I don't want to go that route. I just want to wind down with my family around me. And say, well, then you've got hospice that can help you with that. If you want, there's also medical aid in dying. Would you like to know more? It's a conversation. It's not just one checklist, but that's required. To talk about medical aid in dying with a patient, you have to cover all of the options.
Dr. Gardner, when we're dealing with things in regards to the privilege of dying, right? There seems to be some type of there seems to be disparity in regards to how people die.
Yeah. Absolutely, and we see that in the statistics looking at black people, African Americans versus whites. When it comes to blacks versus whites, we tend to see more blacks dying in ICUs versus whites. We tend to see more whites having hospice care versus blacks. So there are all sorts of health disparities, but as well end-of-life health disparities, because this is really about healthcare from beginning till end. So one of the things that we've been doing is making sure that we get the word out there as to what are all of the end-of-life choices that are out there, not just medical aid in dying, but the importance of hospice care, the importance of palliative care, and so on, and of course, the importance of being able to get that information to the masses. But a lot of the work that we've been doing is getting it out through the clergy, because they have such an important relationship.
That has to be a big one, Doc,
Yeah.
with clergy. It has
Talking
to
to
be.
clergy, talking to doctors, but talking around the issues around religion and so on, because Black Americans are very much, into their religion for the most part. And so this is how we are trying to make sure that this isn't about privilege, but it's about equal access.
So how does one get this? Is this something that's supported by insurance? I mean, or is this a private cost, private decision? Insurance companies won't
So
kill you, so to speak.
the law does not mandate anything as far as coverage. That's up
Okay.
to the insurance company.
because that will cause another.
Absolutely. And insurance companies don't they don't want to be involved with this because they don't want to be seen as either supporting it or opposing it. They're like, we're agnostic on that. Okay. So what will most often happen is you'll have to pay the bill for the medicines. I think it's on the order of $2,000, $2,500 or so, which gets back to the privilege issue. One of the things, because again, a quarter of the country is eligible for this, lives in a jurisdiction where it's legal, including Washington, D.C., we've got examples of how this can be, and Dr. Jeff talked about, when there's outreach to the vulnerable communities, make sure that they know, here are the choices, and if there's a financial need, here are some organizations that in the past.
So there's organizations that will help you with the cost.
I'm saying that all that's possible.
Okay.
So I mean, that's up to the organizations. We're not going to be mandating that in the law.
Okay.
But we are going to say, here are your choices, and compassionatechoices.org will have, and here's how vulnerable communities have. You can find out more from those who are where this is legal in another jurisdiction, and find out, do you have any programs, and how did you get that program up and running? Because we haven't become law yet in Delaware, we haven't invented that.
Right.
But that is certainly something that organically we can be hoping and building.
One thing I've known, I lived in Delaware most of my life, right? I went away for school for a couple of years, but for the most part, Delaware has been my home. I understand Delawareans. I understand the people. I understand the people of Wilmington very well. So what's happening is, I think a lot of people are questioning motives. Why are folks, and both of you are very passionate about this, and you're well-versed in this as well, but what is it that's making you, Representative Baumbach, Dr. Jeff, so passionate about an issue that I think is so final?
So let me start, and I'm going to talk about Jerry, my father-in-law, who's passed away. One of my careers has been as a financial planner. And part of that is, if your in-laws have some questions, you answer the questions. And we spoke about what he and his wife wanted. And one of the things he didn't want to die in a hospital hooked up to tubes. Okay. And he's blue collar. He worked at Johnson Controls down in Middletown most of his life. And he's go forward some years, and we've written stuff down. My son and I were out of town on a service trip, and he entered the hospital. And when we got back from the service trip, visited the hospital, and he was hooked up to tubes. And he was intubated, he couldn't speak. And he looked at me, and his eyes screamed at me.
Said, I told you this is
I
not
told you not to do this,
Right.
okay? And that has motivated me, because we have people who have very strong directives, and there are seniors, and we owe them to follow their directions. And yet, without this law, we're prohibited to do that. And that's wrong. That's just wrong.
It is. I appreciate your candor. Dr. Jeff?
What really drives me for this is something that's very personal. For one, I've worked with so many patients and their families who I see have gone through this kind of pain, who feel that, at some point, the way that they were dying was absolutely horrible. It was absolutely horrible for the families. That's not, I believe, the natural order of things, quite honestly. But even more personal, I think about myself. Now at the age of 68, I know that even though I have many years ahead of me, hopefully, I work out like my colleague every day. But I know at some point I will face death. And I just want to know right now, whether I will have choices as to how I die versus how I lived, within the confines that we talked about, 6 months or less, being in horrific pain, knowing that there's no hope of going any further. I want to have a quality of my life at that time and not have my family suffer along with me in that way. So this is something that, I've thought about. It may be part of my epitaph. I've spoken to my children about that. But, if you talk the talk, you walk the walk. I've seen this happen to so many people. And therefore, this is what I always keep in mind, that I don't want to see other people suffer in that way. I know I wouldn't want to suffer in that way. Mm-hmm. This is the choice I make for me. I don't keep anyone from making the choices they need to make for themselves. If they don't believe in medical aid in dying, good for them. That's their choice. If I believe in it, or 70% of Americans believe in it, as we know, that's a statistic, then, good for them. That's their choice.
Thank you, gentlemen, for joining us right here on the agenda. We appreciate it.
Thank you for your time. Thank you for your questions.
These are very important topics. And House Bill 140, as always, is very important to Delawareans. We're making sure that this information is well known for you to make your choice. Let's be very honest, that's what it is. It is a choice for you to make in your time of dying, for your family to make. Hopefully, we're all having that conversation with our family in regards to planning prior to the event, right? So it doesn't catch us by surprise. So you're not there with the tubes and down your throat before even having an opportunity to say no. And have that difficult conversation, not only with your family, but with your clergy. Understand where your options are. Again, it's a choice. And we're glad that we had the opportunity to give you all the options right here on the agenda. We look forward to seeing you next time, right here.